Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. So next, I would like to introduce you all to today's guest speaker. Joining us today, we have Dr. Manisha Bahl. Dr. Bahl is a breast imaging radiologist at Mass General, an associate professor of radiology at Harvard Medical School, and a fellow of the Society of Breast Imaging. Her research focuses on the use of artificial intelligence to improve outcomes in women with early-stage breast cancer and high-risk breast lesions. She has given more than 100 invited lectures and is an award-winning teacher and mentor. In recognition of Breast Cancer Awareness Month, she joins us today to give a talk on screening for breast cancer. So please join me in welcoming Dr. Bahl.
Thank you so much for that kind introduction, Amy, and for the invitation to speak. I'll pull up my slides. Thank you to everyone for joining today's session. I'll begin with a few comments about breast cancer. We'll then discuss the imaging modalities that are currently used for breast imaging, mammography, ultrasound, and MRI, in addition to two emerging technologies, contrast-enhanced mammography and artificial intelligence. We will next review breast cancer screening and recommendations for screening, and I'll conclude with several interesting imaging cases. Then there will be an opportunity to ask any questions that you may have about breast cancer and breast cancer screening. I'll also share with you my email address in case there are any questions that we don't address or questions that arise later. As a way of introduction, breast cancer is the most common cancer diagnosed among women in the United States. It is the second leading cause of death from cancer among women after lung cancer. Breast cancer can begin in different parts of the breast, such as the milk ducts or the lobules. Breast cancer can spread outside of the breast through blood vessels and lymphatics. When breast cancer spreads to other parts of the body, it is said to have metastasized. There are multiple risk factors for breast cancer. The two most significant risk factors for developing breast cancer are being female and increasing age. Breast cancer can present with symptoms such as lump or nipple discharge or dimpling of the skin. Women can have breast cancer without having any symptoms at all, which is the reason that we encourage screening tests. We'll next discuss the modalities used in breast imaging. The first modality is mammography, which is an X-ray of the breasts. There are two types of mammograms, screening and diagnostic. Screening mammograms are done in women who don't have any symptoms, such as lump or nipple discharge. 4 views total of the breasts are obtained, 2 of each breast, which I'll show you in a few moments. Diagnostic mammograms, on the other hand, are done in women with symptoms and in patients who are recalled from screening mammography for further evaluation. Specialized mammographic views are obtained, such as magnification views or spot compression views, depending on the reason for the diagnostic mammogram. One other difference between screening and diagnostic mammograms is workflow. Screening mammograms are typically batch read by a radiologist after the patient leaves the facility, and she's called back if any abnormalities are noted on the mammogram by the radiologist. Diagnostic mammograms, on the other hand, are interpreted in real time by the radiologist. The appropriate mammographic views are obtained, and ultrasound may be done for further evaluation. The radiologist will then typically discuss the findings and recommendations with the patient before she leaves our clinic. This is an example of a screening mammogram. There are four views obtained: a craniocaudal view of each breast, in which the breast is compressed like a pancake, and a mediolateral oblique view of each breast, in which the breast is compressed from side to side. Findings on mammography include mass, architectural distortion, and calcifications. This first patient has 2 masses in the breast, which turned out to be multifocal breast cancer. This next patient has architectural distortion, in which the breast tissue appears distorted with no definite mass visible. Distortion is a highly concerning finding unless the patient has had prior surgery to that breast. Calcifications appear as white dots on the mammogram. The reason that we investigate calcification so thoroughly is to rule out the possibility of ductal carcinoma in situ, or DCIS, which is also known as stage 0 breast cancer. DCIS, or ductal carcinoma in situ, often presents with calcifications on mammography. With DCIS, cancerous cells are present, but those cancerous cells are confined to the milk duct. If the cancerous cells break through the milk duct into the surrounding breast tissue, then the patient is considered to have invasive breast cancer. Thus far, we've focused on 2D mammography. Tomosynthesis, also known as 3D mammography, is quickly becoming the standard of care. With 2D mammography, 4 views of the breast are obtained, and there are 4 images total to interpret. With tomosynthesis, or 3D mammography, the same 4 views of the breasts are obtained, but there are multiple thin images of the breast to interpret. Multiple research studies have shown that tomosynthesis, or 3D mammography, has led to higher cancer detection rates and lower false positive rates compared to 2D mammography. Here's an example of a left 2D craniocaudal view on the left side of the screen and the corresponding tomosynthesis images on the right. I'll click on the play button here to scroll through the tomosynthesis images. There's a small cancer with spiculated margins, and that cancer is better seen on the tomosynthesis images, and its margins are better characterized on the tomosynthesis images compared to the 2D mammogram. The first sentence in our mammography reports is a comment about breast density, which is a subjective estimate of the amount of fibroglandular tissue or breast tissue relative to fatty tissue. According to the BI-RADS Atlas, which is a standardized lexicon that we use in breast imaging, breast density should be classified into one of 4 categories: almost entirely fatty, scattered areas of fibroglandular density, heterogeneously dense, and extremely dense. Approximately 10% of women have fatty breasts, 40% have scattered areas of fibroglandular density, 40% have heterogeneously dense breast tissue, and 10% have extremely dense breast tissue. Women in these last two categories are considered to have dense breasts. The importance of breast density is twofold. First, dense tissue can mask abnormalities and therefore decrease the sensitivity of mammography for the detection of breast cancer. Second, the presence of dense tissue has been identified as an independent risk factor for the development of cancer. Although increased breast density confers lower risk than other risk factors such as family history, it's more common in the general population, and some researchers have suggested that breast density alone accounts for a considerable proportion of cancer risk at the population level. Fueled by patient advocacy groups, many states have adopted legislation requiring radiology facilities to disclose breast density information directly to patients. Many states have language in their laws recommending that patients discuss options for supplemental screening with their physicians. The laws state by state vary considerably. Some states require only that patients be notified that their breast tissue is dense, while others specify that supplemental screening with ultrasound and/or MRI be offered. The states with the black stars are the only ones that mandate insurance coverage of supplemental screening. The Food and Drug Administration issued a long-awaiting rule in March earlier this year that standard breast density notification will be required in all mammography reports beginning in September 2024. Reports will state that breast tissue can be either dense or not dense. Dense tissue makes it harder to find breast cancer on a mammogram and also raises the risk of developing breast cancer. Your breast tissue is dense. In some people with dense breast tissue, other imaging tests in addition to a mammogram may help find cancers. Talk to your healthcare provider about breast density, risks for breast cancer, and your individual situation. As a side note, the imaging tests that can be used in addition to 2D mammography and 3D mammography or tomosynthesis are ultrasound, MRI, or contrast-enhanced mammography, each of which we'll discuss in turn. The next modality that we'll discuss is ultrasound. Ultrasound is used to characterize mammographic findings. For example, a mass seen on mammography can be cystic or solid, and ultrasound evaluation can differentiate between fluid-filled cysts and solid masses. Ultrasound can also be used to evaluate lumps, focal pain, or nipple discharge. Ultrasound is almost always performed to further evaluate symptoms such as a lump, even if the mammogram is normal. Ultrasound is used for procedural planning since most biopsies are performed under ultrasound guidance. Whole breast ultrasound can be used to screen for breast cancer, although this is a controversial indication for ultrasound. In the average risk woman, the number of additional cancers detected with whole breast ultrasound after a negative tomosynthesis or 3D mammogram is quite small. Also, ultrasound can lead to the detection of findings that aren't clinically significant, that aren't breast cancers, but that do require follow-up evaluation or biopsy. However, many practices do offer whole breast ultrasound screening, especially to women with dense breast tissue. Here's an example of the use of ultrasound. This patient has a large mass in the left breast, which could be fluid-filled cystic, or it could be solid. Ultrasound was done for further evaluation, which shows this black or anechoic mass representing a benign, non-cancerous simple cyst. By contrast, this image shows the ultrasound appearance of an invasive breast cancer. The cancer has irregular margins and is heterogeneous, very different in appearance from the simple cyst. The next modality that we'll discuss is MRI, breast MRI. The two primary indications for MRI are high-risk screening in women who have greater than 20% lifetime risk of breast cancer, and extent of disease evaluation in women with biopsy-proven cancer. We'll discuss high-risk screening later. There are also some less common indications for MRI, such as evaluation of silicone implant integrity. Here's an example of the use of MRI. This patient has a known cancer in the right breast, which was identified by mammography and biopsied under ultrasound guidance. MRI is the most sensitive of the imaging modalities that we use, and in this case, it was performed prior to surgery to better evaluate extent of disease. In the other breast, the contralateral breast, suspicious non-mass enhancement was seen. This non-mass enhancement was biopsied under MRI guidance, with biopsy yielding additional disease, additional breast cancer. When we perform MRI exams for extent of disease evaluation in women with biopsy-proven breast cancer, it's uncommon to detect additional disease in the other breast, occurring in less than 5% of cases. It's much more common to detect additional disease in the same breast as the known cancer, the ipsilateral breast, which occurs in about 15% of cases. Next, I'd like to discuss emerging technologies in breast imaging. First is contrast-enhanced mammography, or CEM. With CEM, a mammogram is obtained after injection of iodinated contrast material, similar to the contrast material that's given for CT or CAT scans. This first image is a conventional 2D mammogram showing dense breast tissue. The second image is a contrast-enhanced mammogram, which shows an enhancing mass that proved to be a breast cancer. This mass, this cancer, is much better seen on the contrast-enhanced mammogram and the contrast-enhanced MRI compared to the 2D mammogram. Multiple research studies have shown that contrast-enhanced mammography has similar sensitivity to MRI for the detection of breast cancer. The advantages of contrast-enhanced mammography are that it's more accessible and less costly than breast MRI. At my practice, we are just beginning to use contrast-enhanced mammography, and it's primarily being used to evaluate extent of disease in women with biopsy-proven cancer who are not able to undergo MRI because of claustrophobia or the presence of a metallic implant like a pacemaker. The next emerging technology that I'd like to discuss is artificial intelligence, or AI, which is a research interest of mine. There are more than 20 Food and Drug Administration cleared AI algorithms for breast imaging, which are increasingly being used in the clinical setting. This screening mammogram shows a small cancer in the upper outer quadrant of the left breast, which is circled and was identified by the AI algorithm. In a reader study with 14 radiologists, only 4 of the 14 radiologists identified the cancer without the use of AI. With the use of AI, 11 of 14 radiologists correctly recalled this patient for further imaging evaluation. Here's another imaging example. This small cancer indicated by the orange box was missed by 6 radiologist readers in this study, but correctly identified by the AI system. AI, however, is not perfect. The cancer indicated here by the orange box was detected by all 6 radiologists in the study, but it was missed by the AI system. At this time, none of the commercially available AI algorithms have been approved by the Food and Drug Administration for standalone use. All of the algorithms require radiologist involvement and oversight. The next topic that we'll discuss is screening for breast cancer. The purpose of screening is to detect breast cancer early when treatment is more effective. When breast cancers are found early, there are more options for less aggressive treatments. Population-based randomized controlled trials of screening mammography have individually and collectively provided strong support for the efficacy of breast cancer screening. While the mortality benefit of screening mammography is recognized by everyone, some of the controversies focus on when to start screening and how often to get screened. The Society of Breast Imaging, American College of Radiology, United States Preventive Services Task Force, and American Cancer Society all agree that the most years of life and most lives are saved by starting screening at age 40. The Society of Breast Imaging, or SBI, and the American College of Radiology, or ACR, recommend that screening start at the age of 40 and that women undergo screening every year, annually. The United States Preventive Services Task Force, or USPSTF, just released updated guidelines a few months ago, also recommending that screening start at the age of 40. Previous USPSTF guidelines had recommended starting at the age of 50, but the USPSTF now endorses starting at the age of 40. Unlike the Society of Breast Imaging, or SBI, and American College of Radiology, ACR, the USPSTF recommends every other year screening, biennial screening, rather than annual screening. Per the USPSTF, every other year screening provides most of the benefits with less of the harms. The argument that biennial screening provides most of the benefits comes from models comparing various screening strategies. Screening every other year or biennially maintains an average of 80% of the benefit of annual screening. In some of the models, however, the benefit is as low as 60%. While I understand these results, the flip side is that we could avert approximately 20% of breast cancer-related deaths with every year annual rather than biennial screening. The American Cancer Society recommends that women with an average risk of breast cancer should undergo regular screening mammograms starting at age 45. Women aged 45 to 54 should be screened every year. Women 55 years and older should transition to every other year screening or have the opportunity to continue screening every year. The American Cancer Society does note that women should have the opportunity to begin annual screening at age 40, although their strong recommendation is to begin at age 45. With regard to when to stop screening, the USPSTF concludes that the current evidence is not sufficient to assess the balance of benefits and harms of screening mammograms in women aged 75 and older. However, the Society of Breast Imaging, American College of Radiology, and American Cancer Society recommend continuation of screening past age 74 unless a patient has severe comorbidities that limit overall life expectancy. For the average woman in the United States, her lifetime risk of breast cancer is 12.5%, or 1 in 8. We define high risk as those women with greater than 20% lifetime risk of breast cancer. Average is 12.5%, high risk is greater than 20%. For high-risk women, annual screening MRI in addition to annual screening mammography are recommended. High-risk women are often screened with mammography and MRI every 6 months. That is, she undergoes her mammogram, 6 months later MRI, 6 months later mammogram, etc. Some high-risk women choose to undergo screening once a year and undergo mammography and MRI on the same day. However, this alternating 6-month schedule is much more common. Women with BRCA mutations, certain genetic syndromes that predispose them to breast cancer, and a history of radiation to the chest at a young age are eligible for breast MRI, and insurance would cover breast MRI in those settings. Other women reach this 20% or high-risk threshold that qualifies for MRI because of a combination of risk factors, such as family history and reproductive risk factors. There are multiple tools available to assess an individual woman's breast cancer risk, such as the one shown here. This tool asks for current age, reproductive risk factors such as age at time of first live birth, family history, personal history of breast biopsy, and race ethnicity. If I see a woman in breast imaging clinic who's concerned about her breast cancer risk, or if I'm concerned about her risk, I'll typically refer her to a specialist who can determine the appropriate risk assessment tool to use and then guide the patient with regard to what to do with this information about risk. Now, when I read 1,000 screening mammograms done in women who are aged 40 or older without any symptoms, I'm expected to recall 10% or less of these women for additional imaging. Of the women that I recall for further imaging, only 5 will statistically have breast cancer. Therefore, out of every 1,000 screening mammograms that I interpret or one of my colleagues interprets, I'm expected to detect about 5 breast cancers total, 5 breast cancers out of every 1,000 screening mammograms. This diagram further explains the numbers. For every 1,000 women who have a screening mammogram, 100 out of the 1,000, or 10%, will return for additional mammogram and or ultrasound due to something seen on the initial mammogram. 61 will have the additional imaging done and find that nothing is wrong. 20 will find out what was seen on imaging is likely not cancer and will return in 6 months to keep watch on the finding. Of the 100 patients who are recalled for additional imaging, 19 statistically will end up having a needle biopsy, and only 5 of those women will be diagnosed with breast cancer. Next, I'd like to share some interesting cases in order to describe how abnormalities on imaging are managed. Now, all of our reports, whether it's a screening mammogram, a diagnostic mammogram, an ultrasound, or an MRI, will end with a number, 0 to 6, which reflects the radiologist's overall assessment. BI-RADS 0 is used for screening mammograms when the radiologist wishes to recall the patient for additional imaging. So of the 1,000 screening mammograms that I interpret, approximately 10% or 100 of those patients will be given a BI-RADS 0 assessment and be recalled for additional imaging. BI-RADS 1 means that the imaging study is negative without any evidence of breast cancer, and the patient should resume screening. BI-RADS 2 also means that there's no evidence of breast cancer and that the patient should resume routine screening. However, with BI-RADS 2, the radiologist does report benign or non-cancerous findings in the breast, such as benign calcifications or benign masses. BI-RADS 3 is the most confusing of the categories. It means that there is a finding on imaging that's probably benign. The risk of cancer is thought to be greater than 0%, but less than or equal to 2%, and 6-month follow-up is recommended. BI-RADS4 means that the finding is suspicious, risk of cancer is greater than 2%, and biopsy is recommended. BI-RADS5 means that the finding is almost certainly a breast cancer given the imaging features, and biopsy is recommended. BI-RADS6 is used for known biopsy-proven cancers before a patient has undergone treatment for surgery. For example, if a woman is undergoing chemotherapy before surgery, she may come to breast imaging clinic for an ultrasound check to assess tumor size. I would perform the ultrasound and report the case as interval decrease in size of known cancer, compatible with treatment response BI-RADS6. Next, we'll review a series of cases to illustrate how abnormalities are worked up and managed. These images are in order: the patient's prior left CC2D mammogram, current left CC2D mammogram, prior left medial lateral oblique 2D mammogram, and current left MLO 2D mammogram. I'll give you just a moment to look at the images to determine if there's something new on the current mammogram compared to the prior mammogram. And I'd focus on these last two images, the MLO images, where the finding is seen best. Now, there is a new finding on the current mammogram, which is this very small mass. I would code the screening mammogram as a BI-RADS0, additional imaging evaluation needed, and my patient coordinator would call the patient and ask her to come in for a diagnostic mammogram and possibly an ultrasound. The patient now returns for a diagnostic mammogram. Instead of compressing the entire breast, we compress just the area that we're interested in. Spot compression of that finding shows that it persists. So I would next want to further evaluate this finding with ultrasound. On ultrasound, a small irregular hypoechoic mass is seen, which is coded as a BI-RADS4 biopsy recommended. The biopsy result was an invasive ductal cancer, an invasive breast cancer. Now, this case is a favorite of mine for two reasons. One, it shows why we perform screening mammography in the first place, to detect small, non-palpable breast cancers like this one, which can be treated and cured. Two, it shows the importance of prior mammograms. This finding is much easier to detect because we have a prior mammogram that can be used for comparison. Whenever a patient transfers her care to our facility, we always make great effort to track down her prior mammograms for comparison purposes. This next patient presents for evaluation of an area of palpable concern in the left breast. She is a diagnostic patient since she has symptoms, not a screening patient. Now, the finding here is quite obvious. It's this high-density spiculated mass with associated skin retraction, and there's involvement of the pectoralis muscle. Involvement of the muscle can also be seen on the MLO view here. The next step would be evaluation with ultrasound. On ultrasound, an irregular mass is seen for which biopsy was recommended by BI-RADS4. The mass was biopsied under ultrasound guidance, yielding an invasive cancer as we expected. This next case is also an interesting one. This patient presented for evaluation of a lump in her right axilla, her right underarm, as indicated by this triangular marker. That's a sticker that the technologist placed on the breast to indicate what the patient is feeling. Now, the patient is feeling these enlarged axillary lymph nodes, enlarged lymph nodes in the underarm. There were no other abnormalities on the mammogram. We then took her for ultrasound evaluation, which showed very abnormal appearing lymph nodes. Biopsy was recommended by BI-RADS4, which yielded metastatic cancer, likely breast primary. Since we couldn't see the primary breast cancer well on the mammogram, MRI was appropriately performed. This subtraction MR image shows non-mass enhancement in the right breast, which was biopsied under MRI guidance to yield invasive cancer as expected. This case is quite unusual, one of the few cases that I've seen in which the primary breast cancer is not well seen on the mammogram. This next patient presented for screening mammography and was found to have calcifications in the left breast. This exam was coded as a BI-RADS0, and the patient was brought in for a diagnostic mammogram. Here is a diagnostic image. It's a magnification view of the calcifications. The magnification view shows suspicious calcifications for which biopsy was recommended by BI-RADS4. Calcifications are typically biopsied under mammographic or what we call stereotactic guidance, with either a prone table in which the patient lies on her belly or an upright table in which the patient sits upright. Our facility transitioned from the prone table to the upright table several years ago. Now, this procedure to biopsy calcifications is fairly quick, approximately 15 minutes total on average. Before the patient leaves the room, we do take an X-ray of the specimen obtained, of the tissue that we've obtained, to ensure that we have a good sample of calcifications to send to our pathologists. Biopsy of calcifications is performed to rule out ductal carcinoma, in situ, or DCIS, which is non-invasive or stage 0 breast cancer. This last case comes from a woman who presented with 2 areas of clinical concern, 2 lumps, which are indicated by those triangular markers. At this site, there wasn't anything seen on the mammogram, nor was there anything seen on the ultrasound. At this second site, there's dense breast tissue seen, and on ultrasound, we did see a hypoechoic mass for which we recommended biopsy by BI-RADS4. Biopsy was done, and it yielded diabetic mastopathy. Diabetic mastopathy is a benign condition. It's non-cancerous. It develops in women who have long-standing insulin-dependent diabetes. Now, the reason I show this case is to highlight that we just can't always distinguish between benign findings and cancers on imaging. This benign condition, diabetic mastopathy, has the same imaging features as breast cancer. Even if I had known the patient's history that she had long-standing insulin-dependent diabetes, I still would have recommended the biopsy since the imaging features of diabetic mastopathy and breast cancer overlap. In summary, the primary modalities that we use to image the breast are mammography, both 2D mammography and tomosynthesis, ultrasound, and MRI. Tomosynthesis, also known as 3D mammography, is associated with higher cancer detection rates and lower recall rates or false positive rates than 2D mammography, and tomosynthesis is quickly becoming the standard of care across the United States. Ultrasound is used to characterize mammographic findings, evaluate women with symptoms, and plan procedures. Many of our procedures are done under ultrasound guidance. Whole breast ultrasound can be done for screening purposes. The 2 primary indications for breast MRI are high-risk screening in women with greater than 20% lifetime risk of breast cancer and extent of disease evaluation in women with biopsy-proven cancer. Emerging technologies in breast imaging, which are very exciting, include contrast-enhanced mammography and artificial intelligence. The importance of breast density is twofold. First, dense tissue can mask abnormalities and therefore decrease the sensitivity of mammography for the detection of cancer. Second, the presence of dense tissue has been identified as an independent risk factor for the development of breast cancer, independent of that masking effect. The goal of breast cancer screening is to detect breast cancer early when treatment is more effective. The Society of Breast Imaging, American College of Radiology, and United States Preventive Services Task Force agree that screening should begin at age 40, but recommendations differ with regard to annual, every year versus biennial, every other year screening. Approximately 10% of women are recalled from screening mammography for further imaging, BI-RAD 0, and the cancer detection rate is approximately 5 per 1,000 exams. So of those 100 women recalled from the 1,000 screening exams, approximately 5 will be diagnosed with breast cancer. That concludes my presentation. Thank you so much for your attention. I'm happy to answer any questions.
Thank you so much, Dr. Bahl. We are now at the end of the session, so if you have any questions, feel free to enter them in the chat. We have a question where an attendee saw an article about how breast self-exams may not be too beneficial in detecting breast cancer. Can you tell us a little bit more about that?
Yes, certainly. That's an interesting question. There are at least 2 randomized controlled trials that have shown that breast self-exam doesn't lead to a decrease in breast cancer-related mortality. Screening mammography, however, has been shown to lead to a reduction in breast cancer-related mortality, but not self-exams. In fact, self-breast exams in those trials was found to lead to more biopsies of benign findings, of non-cancerous findings. We certainly encourage women to be aware of their breasts. It's called breast self-awareness. We know best what normal and abnormal may be for us. But we certainly don't want to replace breast self-exams. We don't want to replace imaging with self-breast exams. The purpose of screening, the purpose of imaging is to detect breast cancers before there are any symptoms, at which point they can be treated and cured, and there are more options for less aggressive treatments. So while we, encourage women to be aware of their breasts and of course note any changes, we highly, encourage women to undergo screening and not rely on breast self-exam.
Thank you. We have a question regarding artificial intelligence. Are there any specific breast conditions or abnormalities where AI can either excel at detecting or struggle with detecting?
That's a great question, and research is certainly in progress. I would say that AI algorithms have been shown to be sensitive for the detection of various types of breast cancer, but AI algorithms have not been shown to outperform specialized breast imaging radiologists. There are certain finding types that can be more difficult to detect by the AI algorithm depending on the way in which the algorithm was trained. So we found that some algorithms have not been trained as well on calcifications, for example. So they are trained with masses and architectural distortion, but not the specific finding type of calcifications, and therefore aren't as sensitive for the detection of calcifications, which is often related to ductal carcinoma in situ or stage 0 breast cancer. But I would say the strengths and limitations of algorithms differ based on the vendor and the specific training set and size of the training set used for development of the AI algorithm. I think ultimately, though, it is highly unlikely that AI algorithms will replace radiologists or that they'll be used for standalone interpretation. Best performance has been shown with what we call, man and machine working together. The radiologist interpreting the exam with the aid of AI, that's consistently shown that the best performance versus radiologist alone versus, AI algorithm alone.
Thank you. Our next question is regarding BI-RADS and ultrasounds. Can you kindly guide about the dilated duct with or without echoes, or whether or not there are any solid masses?
Yeah, that's a great question. If we see echoes or, a mass in the duct, that is typically recommended for biopsy, BI-RADS 4, and specifically a BI-RADS 4B. The type of mass that most commonly grows in the duct is called a papilloma and can be associated with nipple discharge. So when a patient presents with nipple discharge, particularly if it's bloody, the most common finding we see is a papilloma in the milk duct. It can be challenging, though, on ultrasound to distinguish between a mass versus, debris or echoes. If the echoes and debris are moving, during my real-time ultrasound scan, I can be more confident about that and not recommend biopsy. But if there's any question that there could be a mass, we do typically code it as a BI-RADS 4, BI-RADS 4B, and recommend a biopsy to evaluate for papilloma or even, papillary carcinoma or DCIS, which can be found in the ducts.
Thank you. Earlier in your presentation, you had discussed the SBI ACR as well as the USPSTF guidelines of screening starting at age 40 every year versus every other year. What does MGH follow in terms of someone who has average risk?
That's a great question. MGH follows the SBI, Society of Breast Imaging, and ACR, American College of Radiology recommendations, which is to start screening at age 40 for the average risk woman and be screened every year, and to continue that screening until there are, 8 to 10 years of life expectancy remaining. We don't have a hard cutoff for stopping screening. It depends on the individual patient's preferences and overall health status.
Thank you. Well, wait to see if there are any additional questions in the chat. Do you have any final thoughts you'd like to share with the audience, Dr. Bahl?
Well, thank you so much for your participation. And I hope this information was helpful to you. If there are any questions that arise later, please feel free to email me. I'll just share my email address again here.
Wonderful. Thank you so much. I don't see any further questions in the chat, so I think it's okay to end a few minutes early. Thank you so much for spending the hour with us, Dr. Bahl. This was extremely helpful. And everyone who has joined today's session, thank you so much. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. It'll be made available within a few weeks. All right, everyone. Thank you so much. Have a lovely rest of the day.
Thank you.